Good afternoon. I'm so excited to see so many faces here. I am, as she said, I'm Dr. Deatsman. I am an OBGYN here at UF Health, and today I am going to talk to you about the menopause journey and what you need to know. So that crazy word menopause is something that I think everybody's hearing more and more these days. It's all over. And it brings a whole host of a lot of questions with it. Like, what is menopause? What about perimenopause? And then there's all these different things that you start to hear. Hot flashes, night sweats, painful sex, memory issues, maybe some joint aches and pains. And then the big one that comes up is hormone therapy. And you know, there's a lot of things out there these days, and it's really hard to sort through the information of whether this is something that is needed, necessary. You hear that, oh no, estrogen's bad. Oh no, estrogen's good, or in some people say estrogen's great. And then you have things like TikTok and Instagram that are complicating our lives in lots of different ways, but definitely in this instance can make things really difficult to sort out what is really important in this time period. So I thought today we could just kind of talk about some pretty basic definitions about the menopause and perimenopausal time periods, and just give you some information about how to make this time period and the time after it, which is an important time in women's life, something that is healthy. If you were here for Dr. Bracewell's wonderful talk, you're going to hear me preach about of those lifestyle factors too, so I'm just going to say you'll be encouraged to adopt some of those things if you aren't doing them already. So what is menopause? This is really just a definition of when menstruation has stopped. And perimenopause is that transitional time when someone goes from having regular menses to their final menstrual period. Menopause is actually something that's diagnosed in reverse. You don't really know you're there until it's happened. But it's when somebody has been having menstruation and then they've gone an entire year without having a period. This isn't perfect by any means, but this is what our general definition of this is. And women, because we are living long, healthy lives, will spend a third of their life in this time period. So really trying to approach health at this point is critical to make sure when someone's living a long, healthy life. The average age of menopause in the US is about 51, and this can be really variable from person to person. Premature menopause is diagnosed as anybody who has menopause before the age of 40, and then early is somebody who is between 40 and 45. Perimenopause, like I said, is that transitional time period. This is, I think, the thing that we're hearing a lot more about these days, just that women can start to experience a lot of symptoms well before their periods stop. And on average, this is the part where I tell my patients to not throw their shoe at me, but it can last for 4 to 8 years. So on either side, women can have symptoms for up to a decade leading up to that final menstrual period, and even for a number of years afterwards. This will typically start in the mid to late 40s. Like I said, here in this country, menopause is usually around 51, but because that is so variable, some women can experience these symptoms as early as their mid-30s. All right, so what are these different things that we're going to talk about that are those signs of peri and menopause? So abnormal bleeding, vasomotor symptoms, that's kind of that hallmark symptom that a lot of us talk about, those hot flashes and night sweats. Mood or memory changes, sleep disturbances, changes to our skin. A big one that for a lot of my patients are changes in weight, vaginal and vulvar changes, and then, like I was saying, bone and joint issues. So we'll kind of break these down, each one. Abnormal bleeding, it's not uncommon for women kind of in this transitional part in perimenopause to have changes in their menstrual patterns. Somebody who may have been one of those, I can set my clock every 28 days, here it goes, will start to say, well, now it's every 3 weeks instead of every 4. Some people will see that shortening before they'll see spacing. I tell my patients, sometimes it likes to just go out with a bang and be like fireworks and bleeding a lot. But these are just some of the things that people may experience. They also may see a difference in flow. Things may be lighter as they start to kind of space out, but some women have much heavier bleeding, especially in their 40s. Sometimes this is from a structural cause like fibroids or polyps, but there can be things that are just related to these hormonal fluctuations and changes we're seeing in this time period. So it's really important to kind of delineate what's happening there. When are the times to seek evaluation? Well, if you're bleeding more than every 3 weeks, that's an important one. If that bleeding is much heavier, like those large clots that you're passing, we want to make sure that somebody's not bleeding so heavily that it's changing their blood counts. If you consistently have bleeding that lasts more than 7 days, or like I was saying, if you've gone through that transition and you're considered to be in menopause, you've gone more than a year without a period, any bleeding afterwards is considered postmenopausal bleeding and really should be evaluated. One of the other aspects I tell people here is even if things are still within a normal range, if it's becoming very bothersome to your life, then that's a very reasonable reason to seek evaluation and to seek options for management. Vasomotor symptoms, those are those classic hot flashes and night sweats. This is very different from woman to woman, but 80% of women will experience some form of this in some way. Experience of them can really be variable, and things that may make them more pronounced are having surgical menopause, so earlier, your race or ethnicity, if you're a smoker, what your body weight is, if you have a history of trauma. And some of the things that we're really seeing is women who have worse vasomotor symptoms really are at higher cardiac risk. And so these are important things to just acknowledge. They can be very bothersome, but they can also be warning signs for us about future health. A lot of women will describe them as a feeling of kind of starting in their chest or their neck and then flushing up into their face. Some women will be coated in sweat. Other women will just say that they just kind of feel that hot or internal fire sensation. This can be really disruptive. It can be waking women up at night to the point where they're getting up and changing their sheets because they're so soaked. It's very disruptive to work. The amount of impact that perimenopausal and menopausal symptoms have on the workforce. The Menopause Society put some things out about this within the last 1 to 2 years, and it's like over $1 billion affected in the workforce just because of the disruption it does for women's ability to stay focused at work. These changes are because of the decreasing estrogen, but it also can be some changes in our temperature regulation. And there's lots of different triggers, obviously just those hormonal fluctuations, but things like food, alcohol, stress, anxiety can also try to bring those out a little bit more. There can be mood and memory changes. This is a time, and this is a very frequent complaint of patients in my office, just that they're starting to see this brain fog. They feel like they can't remember things the same, they're losing words, they can't keep their train of thought or stay focused in a conversation. This is also a major impact at work. I have patients coming to me and saying, I think I have ADHD, which sometimes we do actually diagnose in this time period. And women who do have ADHD, this can be a time where it's way worse. So these are things that we do need to kind of sort out. I think some of the bigger things here is that these changes, overall, we see them decrease and people will notice a change, but it's not in their overall executive functioning. It's really in their verbal memory, and good news, it tends to get better, maybe not back to your normal baseline, but better as you're going through that menopausal transition and once in postmenopause. One thing I think is really important to know is that we can see new or worsening anxiety and depression. Women who have a history of depressive episodes can have a worsening of depression during perimenopause and in the menopause transition. And interestingly enough, women who've never had a diagnosis of depression, 1 in 4 women will have enough symptoms to meet the clinical diagnosis of that, even if they've never had it before. Anxiety is another one that bubbles up quite a bit during this time. There's a lot of focus on depression at this point, but anxiety is also something that we're noticing can be worse. Things that are really important, and again, if you were here for the first talk, you're going to hear these things over and over again, but important for brain health, establishing good sleep patterns, and making sure that we're controlling other chronic medical conditions that are coming up at this time, like hypertension and diabetes. Sleep disturbances, again, really this is something that can be seen very frequently, and it may not necessarily just be related to night sweats. There is some data to suggest that just those fluctuations can disrupt this sleep-wake cycle for women, not necessarily even being woken up because they're drenched in sweat. 60% of women will report some kind of sleep disturbance during this time period, and it can be a number of different things that can lead to this, anxiety, medications, issues with bladder control that lead to being up more frequently urinating. So lots of different things could lead to this. Other things in our lifestyle, perimenopause loves to show up at a time in our life when we're often caring for other people. We're maybe parents, maybe children of aging parents. We have a time period in our life when maybe we're really kind of moving things up in our work. And so there are other things that can really impact what's maybe already poor sleep when you have things like work and family stress. But really important to know about this is don't just chalk this up to menopausal or perimenopausal hormone changes. There are sleep disorders that can be a real problem at this point, like insomnia and sleep apnea. So very important to try to get an evaluation and not just brush this off, because there could be things that could be done to help with it. A lot of people will start to talk about the skin changes that they're noticing. Estrogen is important in collagen, and so when there's decreased estrogen, there's decreased collagen, which leads to less elasticity in the skin. Hair may start to thin, and people may notice their part is widening. All of the areas where we have kind of glands that keep our tissue moist have estrogen receptors, and so there will be more dryness noted. Things like in our eyes, our skin, our mouth, or in the vulvar or vaginal area. And again, that flushing may also occur with hot flashes, kind of that redness. And if there's women that already have rosacea, that can be worsening during this time. Weight changes, a very big thing that my patients like to talk about during this point. This is very typical in midlife, and yes, the hormonal fluctuations do change how things are in our body as far as our body composition. We tend to decrease our muscle mass and increase our fat mass, and of course, it loves to live in our weight, in our belly right here. This is something that we see with these hormonal fluctuations, but also there tends to be a change in more sedentary behavior as you're at this age range, so that can also increase this. I think one of the biggest things is to, at this point of life, focus on being stronger, not lighter. We want to do what we can to continue to maintain or even build muscle mass at this point. But there are a lot of options for weight loss these days. If you're doing things for exercise, dietary, and really trying to put in the effort and aren't seeing those, there are lots of options. So making sure you're talking to your doctor about what those might be to help you out. Again, things like poor sleep can lead to weight gain, so it's kind of a vicious cycle. And then weight changes can lead to other things like hypertension or diabetes at this point. So just all of these kind of full circle things. We can have changes in the vulvar and vaginal area. We used to call this vaginal atrophy, which is just vaginal dryness or vaginal thinning. There's a more global term now that we're using, and I think it really kind of encompasses these changes better, and it's just genitourinary syndrome of menopause, so just big fancy term to say, the vulvar, vaginal, urethra, and bladder area, and there can be really significant changes during this time. The skin becomes thinner, less flexible, less pliable, less lubricated. Women may have new or worsening pelvic organ prolapse and things like worsening incontinence. There can be significant change in sexual function related to pain or desire or orgasm, and other chronic conditions that are happening may also play a role here. 1 in 4 women report that menopause actually interferes with their ability or enjoyment in their sexual life. And this is a huge aspect that shouldn't be ignored. If you are someone who wants to maintain a healthy sexual relationship or just activity in your life, these are things that should be addressed. And then there's bone and joint issues. The term musculoskeletal syndrome of menopause was coined about 2 years ago. Even though this is something we know has been kind of a myriad of symptoms for women, now finally has a name, which sometimes then that means it gets a little more attention and maybe some more research and treatment options. We know that decreased estrogen during this time leads to faster bone breakdown. So that can lead to bone thinning and things like osteoporosis. There are other musculoskeletal changes, things like increased inflammation, again, decreased muscle mass, and either new or worsening arthritis. And really, like you're gonna get, I'm drilling this one home, important to really focus on muscle maintenance. This can help prevent bone loss and can also keep us safer as far as from mobility and trying to prevent falls. So what are the management options? So first, I think this is a time I kind of just like to pause and say that we have estrogen receptors from our heads to our toes. So these are just some of the symptoms that you're going to hear women will be experiencing during this time. And again, it's a really varied experience from person to person. And I think one thing to know is this is a normal phase of life. It's a normal transition, and it's not a chronic medical illness. However, there are things that we can do to help manage these symptoms. And again, this is a time period that's critical to really focus on what we can do for women's health for that next stage of their life. I think there's so much out in the media these days that it's really hard to know. We've gone from estrogen's great, give it to everyone, to estrogen's horrible, give it to no one. And I think now we're not really back to the estrogen's great, give it to everyone, despite what you might hear on social media. I think it's definitely, like a lot of things, somewhere in the middle. And so we'll kind of go through a lot of that. But the first we'll talk about is lifestyle interventions, and then we'll get to some of the medical therapies, the hormonal and non-hormonal. So lifestyle medicine, if you were here for the first talk, you kind of heard about the Healthy 8. The International Menopause Society each year picks a topic that they want to focus on for global menopause health, and last year's paper was about the role of lifestyle medicine in menopause care and how it's really important. So this is getting a lot of attention. Yes, there's a lot of attention about estrogen these days, but we really also want to drive home that there's a lot of other things we could be doing to maintain our health. So the pillars of lifestyle medicine are healthy eating, physical activity, mental well-being, minimizing harmful substances, restorative sleep, and healthy relationships. So let's dive into a couple of these. As far as healthy eating, from a menopause or symptom standpoint, there's done a lot of research to kind of see if there are certain things like diet that will help. Plant-based and Mediterranean diet does have some good data to show that it can be helpful with menopausal symptoms. There's a lot of questions in this time period about intermittent fasting. There's definitely two camps that, yes, this is great, and the camp that, no, not so much. I tell my patients, I think if it works for you, that's great, but the data just isn't really clear about it in this time. I think there's a lot more to come on that. But again, we're going to be talking and pushing home that plant-based, so eating that rainbow. Physical activity, the International Menopause Society also recommends 150 minutes of moderate intensity aerobic activity. I think the biggest key here is finding something you enjoy. If you like walking, if you like swimming, if you like, pickleball, that was very big where I just moved from, so I'm assuming maybe it is here. Finding something you can do a few times a week that gets that heart rate up a little bit and helps with our cardiovascular health. But the other part is they also recommend at least 2 days of doing some kind of strength or resistance training. If you want to go out and lift big weights, I'm all about it, go for it, and that's great. But I really just want you to even be doing some body weight or smaller resistance, like resistance band training. We want to keep what muscle mass we have. It's somewhat hard to build muscle mass, but if we can, that's awesome. But doing that strength is critical. Mental well-being, I think we have to remember that there's so many other aspects, but this is a huge part too. We want to focus on stress reduction, different relaxation techniques, and you're going to hear me talk a little bit about CBT a little later on. What about minimizing our harmful substances? Well, if you're still smoking tobacco, please quit. I totally agree with Dr. Bracewell. This is a very difficult thing for our patients to do, and it often takes a lot of tries or different things before doing it, but there's just great data to show that it can be very helpful from a menopausal symptoms as well as just from a cardiovascular standpoint. The recommendation is also to limit your alcohol. It's 10 to 20 grams a day with alcohol-free days is what the International Menopause Society recommends. This is about 1 to 2 drinks a day with those alcohol-free days. Restorative sleep is really important. Seems like 6 to 9 hours is kind of the magic number. There's data to show that less than 6, but also greater than 9 can be detrimental to health. So just trying to aim for that. Again, evaluate for those sleep disorders. And then CBT, for insomnia is a huge help, so something to consider. And then healthy relationships. It is really important to maintain those social connections. That's something that we have excellent data to show that social isolation and loneliness is really important and can be really bad for people's health as we age. And so coming to things like this, getting out, seeing people, and making those social connections are hugely important. Okay, now we're down to the nitty-gritty of hormones. So when I'm talking about hormone therapy, I'm really talking about estrogen because that's really what's changing during this time. So that's the main thing that we're trying to use. So who or what would benefit from systemic, so body-wide estrogen therapy? This is really indicated for someone who's impacted by their vasomotor symptoms, so things like hot flashes and night sweats. It can help some with some mood changes during this time and bone loss prevention, and obviously there can be some benefit for vaginal dryness and painful intercourse. You can see some sleep changes and improvement and some things like joint pain, but right now hormone therapy is not indicated for those things. You may see some downstream effects, but it's not necessarily something that we're prescribing that for. Who should avoid estrogen therapy? Someone who's had a hormone-sensitive cancer like breast or uterine cancer, someone who's had a history of heart attack, stroke, or is a diagnosis of heart disease, somebody who has a history of a blood clot like a DVT or a pulmonary embolism, or somebody with active liver disease. Recommendation for starting estrogen, I think this is also something, especially with the lifting of the black box warning, there's a lot of misinformation out there right now, but really the recommendation is to time this in an important way. It really should be within those last few years around the end of perimenopause into menopause, so about within 10 years of stopping your menstruation, and typically under the age of 60. What are the risks of using this? Breast cancer, there is a slight increased risk when someone uses estrogen and progesterone together, and I'll get into that in just a moment. This increased risk, though, really, if you take a look at it compared to other risk factors like drinking alcohol, eating red meat, it's not something that's substantially different from those. There is actual data to show that using estrogen alone, and again, I'll talk about who can do that, may actually improve breast cancer risk. Obviously, blood clots are a risk. This is more seen with oral. Some people will tell you if you're using a patch or something topical that there's no DVT risk or clot risk. I would never want to say no in medicine. That's not really the best thing to say. And then if somebody's got heart disease, this is the group that we really saw. I think there's so much misinformation right now. Women who were over 60, in their 60s and 70s, when they were started on hormone therapy, remote from their periods ending, these are the people who had more issues with things like heart attack, stroke, clot, and dementia. And so using hormone therapy, that age range recommendation is really based on that data, that we were doing more harm than good when we were taking somebody who is 10, 20 years out from that transition time and putting them on hormone therapy. Some misconceptions, we used to call it hormone replacement therapy. We're really trying to get away from that. It's not replacing. Yes, I know that estrogen's going down, but we're not trying to replace it. We're trying to balance people's symptoms for quality of life. Bioidentical is a marketing term, and so I think there's a lot of push out there to do things that are natural or safe, but really it's something that it was just created to kind of give that marketing push to try to help people think that it was a safer option when in fact it not necessarily is. Another misconception, estrogen is not a magic bullet to fix everything. It's not going to manage or fix all of these symptoms, but it can help when they are very bothersome and disruptive to someone's life. And it's not indicated, no matter what you might hear, for cognitive or cardiac health prevention. There can be some benefits, but it is not currently indicated for that use. So the main thing that we would be using for hormone therapy is estrogen. That's what's changing so much during this time, and it can be found in an oral pill, transdermal, which is usually a patch, gel, or spray, or there's even a vaginal ring, and the dosing varies. We don't check hormone levels to figure out what to use. We really take into account things in a person's history and then adjust dosing based on symptom control. Progesterone needs to be used if somebody still has their uterus in place. If I give somebody who has a uterus just estrogen, I could stimulate cells in that uterus to become abnormal over time and even lead to something like a cancer. So we use progesterone to kind of help keep the uterus safe. This is typically an oral pill. You'll hear a lot of people talking about progesterone creams, but the molecule of progesterone is rather large and doesn't absorb well, and so if someone's using it topically, they may not have enough uterine protection. There is a hormonal IUD that we use for things like contraception and abnormal bleeding, and can actually be used off-label at this point with some specific guidelines. Another very important note, vaginal estrogen is great. And vaginal estrogen can be used by most women. There's very few people who can, and it is not the same as systemic estrogen. A lot of this confusion is because the black box warning was applied to all forms of estrogen when that happened a number of years ago. And there's been a lot of push by clinicians for many years to get it removed from vaginal estrogen. And that was the big push this year, was to get it removed from vaginal estrogen. Then it was removed from everything. So vaginal estrogen is something that is very safe, again, can be used in many women. We're even finding that when somebody has had a hormone-sensitive cancer like breast cancer, that typically, unless there are certain reasons why they shouldn't, they can even use it for local vulvar vaginal symptoms. And it does not cause an increased risk of clot or breast cancer risk. It can be very helpful, not just if somebody's having painful intercourse, but when they're just having dryness and irritation, urinary incontinence symptoms. So I just want to make the point that local vaginal estrogen is different from systemic. What about testosterone? This is going to be real quick. The current only indication for testosterone therapy is for low libido and postmenopausal women. There's no female dosing available yet, so that does make dosing it a little bit difficult. And there can be some serious side effects that can be permanent. And so I think there's also a lot of information about testosterone out there that you should use it for fatigue or improving your muscle mass. We do not have the data for that, and there can be some risks to using it, so it's just something we have to be very careful with. There are a whole host of non-hormonal treatments for somebody who maybe can't use estrogen or doesn't want to. SSRIs and SNRIs are medications that are usually used in anxiety and depression. However, they can be used off-label. There is one FDA approved for actual like hot flashes and night sweats, so it's a low dose. The rest, there are a number that when looked at compared to estrogen, there can be some significant improvement in vasomotor symptoms. Gabapentin is a medication that is often used in pain or in things like diabetic neuropathy, and it can also be used off-label. It can make people pretty sleepy, so it's actually very helpful sometimes to start a woman on it at night to see if it helps with hot flashes and night sweats. People can use it during the day, but it just can lead to increased fogginess, and so just have to be very aware of that. Fezolinetant and olanzapine are two new FDA-approved medications that actually work at the level of the thermostat in the brain. There's estrogen receptors there, just like everywhere else, and it kind of says, okay, hey, thermostat, calm down. I understand there's not as much estrogen, but we're okay. I knew that Women's Health finally made it when fezolinetant had an ad at the Super Bowl like 2 years ago. So I was like, okay, yes. Oxybutynin is a medication that's used in overactive bladder, but can also be used off-label. And then again, it's really important to remember vaginal symptoms. There are non-hormonal moisturizers, and these are two medications that are a prescription that can be used that aren't hormonal. Other therapies, can't say enough good about cognitive behavioral therapy. This can be used for so many things during the perimenopause and menopausal transition. Can be very helpful for hot flashes and night sweats. It's first line for treatment for insomnia. So before using anything for medication purposes, seeing someone for CBTI can be very, very helpful. And the Menopause Society, this is their first line recommendation. CBT can also be helpful from a sexual health and pelvic pain standpoint, and just for stress management. It's also used routinely in things like anxiety and depression. And I like to put the push in here for pelvic floor physical therapy. I'm an OBGYN. I believe every woman should have this at some point in their life, whether you've had a baby or not, there are so many reasons to have pelvic floor PT at some point. And so this is just another really important tool that we can use to help women. What's not recommended? So pellets, compounded therapies, troches, these are not FDA regulated, and this is a lot of where the bioidentical term comes from. These are not FDA regulated, so there's a concern for the accuracy of these. You may be getting subtherapeutic levels. You also could be getting supertherapeutic levels, and to dangerous amounts. Because they're not FDA regulated, they're also not regulated as far as how they're produced and the sterility of it, so that is another concerning factor. And so the thing I like to tell people is a lot of what we use these days are considered bioidentical estradiol that we use in patches and pills is the same estradiol that's in our system. And so just being aware that using these types of methods for delivery, just you're not going to have that safety profile that you will with things that you're going to be able to get a prescription for. And supplements, a lot of these have been really well studied, things like black cohosh, soy, ashwagandha. They have a real popular push to see if they can be helpful, but when compared to placebo, there's no real great effect, and when compared to estrogen, they just don't match up as far as symptom control. Same thing with supplements is that they're not regulated, so we just don't know what's in them, and some actually can have issues with things like trace metals. Important things to consider. So this is definitely going to be a piggyback on that last talk. Not only is this about women's symptoms because of the decreased estrogen, but this is a huge time where we need to be focusing on setting women up for the best health for this next phase of life. We really need to be making sure we're watching for cardiovascular disease and diabetes. We need to be addressing mental health issues, addressing sleep disorders, doing what we can to encourage our healthiest bone, and then making sure we get our appropriate cancer screenings, breast, cervical, colon, and focusing on sexual health. I can't tell you the number of patients I've had come to me in their 50s and 60s that have just been told, well, you're old now. Like, that's just not something you do. And that is completely false. If you choose to not have a sexual relationship, that's fine. But this can be an important part of someone's life and health. And so I think it's something that you should be aware of. There are options. When we're talking about like all of these things, just like Dr. Bracewell mentioned, having a primary, know your numbers, know what your blood pressure is, what are your lipids, what is your weight, even if that's not something we always want to be looking at, what is your blood sugar? These are important things that can help us really hone in on what we can do to make the next few decades very healthy. Get help, create your team. This is one of the things that is, I think, really key to this time. I'm an OB/GYN, so I'm going to plug for you to still see us, even if you're somebody who's not having babies anymore. We still take care of women in all phases of life, and it's very critical to have a primary care who's going to help you with a lot of those other screening and checking other aspects of your health. You may need other specialists at this point. You may need an endocrinologist or a cardiologist, sleep health, mental health, dermatology, and physical therapy. So a lot of people that you may need to be including in your team to help keep you as healthy as possible. When we're talking about menopause and the perimenopause transition, I think it's very important to know where to get good information. There are excellent people, even physicians out there on social media, and some can still be leading people astray. American College of Obstetrics and Gynecology, this is the governing body for OB/GYNs in this country. And they really give us all of our guidelines, everything from pregnancy management, bleeding management, to things like menopause. And so they have really great patient education materials. This is their recently published guidebook that just came out in the last month. It is a little dense, so it is a great resource, but it's not something you're going to finish in an afternoon. And acog.org has information for patients. Menopause Society is another great resource. This is kind of the governing body of menopause care in the United States and North America. So not only does it have OB/GYNs, but it has primary care, cardiologists, endocrinologists, lots of different people. They also have a guidebook just for patients. It used to be $10 on the website, not sure anymore, but it's definitely not quite as dense as the one from ACOG. Excellent information. They also have really great videos and podcasts. You can find information on specific topics, and they help you find a local menopause professional. So they're menopause.org. They also pair with the International Menopause Society that I was talking about, so that they can kind of keep things as far as recommendations on a global scale very consistent. Takeaway points. This menopause, perimenopause transition and in menopause is a very important time for anyone who has menstruated in their life, and it's a very important time for many reasons, from a symptomatic standpoint, but also from a health standpoint. Each person will experience this differently, and it's really critical to take this time to focus on maintaining health and wellness going forward. And yes, you don't need medication at this time if it's not something that you're interested in or you're doing great, but if somebody has symptoms that are really disruptive, there is help. And know that we're here for you. Thank you.